introduce our next speaker, which is Miss Lina Mohammed Obaid from Saudi Arabia. Is that right?
Yeah, it's right. I'm going to share with you, I will share my screen, then I'm not sure if you can see my screen?
Yes, thank you.
Yes, we can see your screen.
Okay, great. Good afternoon, all. Again, this is Lina Obaid. I am the Quality Supervisor in Sultan bin Abdulaziz Humanitarian City from Saudi Arabia. And first, I would like to welcome all of you in our Nursing Healthcare Conference, and to extend my pleasure being one of the speakers today, and to thank you all for the informative presentation. It will add really value to our daily work. Today, I will be introducing one of the most era in our healthcare field that is recently have been introduced in a high reliability organization, which is sustaining culture of safety while implementing a zero harm program. As you know all, over the last decade, zero harm concept and its many variants, including zero incident, zero injury, or even injury-free, has been commonly adopted and expressed. This is a new approach and aiming to protect patients, staff, the organization, even the visitor during the hospitalization period. This is one of the top priority during the hospitalization of the patient, and to provide the patient with an exceptional experience during the hospitalization period. So what is zero harm? Zero harm, as per the Joint Commission, is a zero complication of care, zero fall, zero infection, zero missed opportunity for providing effective care, zero overused, and even zero lost revenue. So in other words, zero harm of any kind. For us, since we start our journey with zero harm, we look to the importance of the zero harm. Zero harm is a critical need. Why? If you, I'm sure you know about the report of the Institute of Medicine in 1999 report, when they published their report about error is a human, and they mentioned that 98,000 of the American people may die every year due to preventable medical error. And even today, we have more than 45 incidents every week in which surgery or any invasive procedure is performed to a wrong patient or use a wrong body part. So in order to prevent this and to protect our patient and to protect our staff, we are aiming in our city for zero harm. So now the second question, and this was very important question even from our staff and our front line, that a human do mistake, and definitely a human do mistake. But at the same time, zero harm does not mean zero mistake. As a human, definitely, especially in the healthcare organization, we can do mistake, but the organization will develop a system and the process to reduce the likelihood of the mistake occurring. So it needs from us within this journey to have extraordinary commitment from everyone to reach the zero harm. So it doesn't happen overnight, but it is possible. So this was our mission when we have implement and start with our zero harm. So in any organization aiming for zero harm, they need to take some steps. And this is what we have started last year. Leadership commitment. The support of the leadership is very important to achieve the goal of zero harm. Frontline alone cannot do this, and middle management alone cannot do this. Zero harm will start from our CEO till reach the front line. Plus, implement the safety just culture. It's very important for our leaders and for our front line, which means ensure that the employee are comfortable while reporting any incident or even report the near miss. And this was the key for our journey or our program. Incorporate a high effective process which use the quality methodology. Teach the staff on how to use the different quality methodology, such as the lean thinking, the improvement model through IHI, the focus BDSA or the BDSA cycle, quick fixes, or even a quality plan. So demonstrate how everyone is accountable for the safety and quality. So everyone needs to commit to the zero harm. And this was one of our results for this one. Excuse me. So to take a step forward for our journey, we start with introduce the concept to our leader. And this was the important step. Zero harm, we cannot start this program without introducing this step to our leaders and to our front line, and to train the leader on the zero harm, on the tool, how to use it, and to select our measures for this one. Selecting the measure of zero harm, or to select the KPI, was the longest step for us, and to look for the leading and lagging KPIs to ensure that we will have a success journey. Then we identify the level of harm, and we study the current trend, and we will speak about this step in the next session. Because studying the current trend of the report, especially the I cannot hear, there is echo. Then we promote zero harm culture through our performance improvement projects. We create a data collection method for a zero harm, and we develop a clear guidelines for our leaders to start with our program, and then we implement and we evaluate our journey. So this is the first we have implement, which is the leadership coaching. We ensure that 100% of our leaders attend our zero harm training, introducing the concept, teaching them about the measures, and teaching them how to use the tool that we're gonna use during the journey. So then we move to our step of measurement or selecting the KPIs. To be honest, we spend really time in studying this step, because finding the perfect measures of safety is a difficult task. So as a special organization, we are not an acute hospital, we are a rehabilitation hospital, mainly providing a care to a rehab hospital. Was really very important for us to select the correct measure that would give benefit to our patients and to our staff. So we were thinking what we can do to select and to look to the measure, to the bottom line result of the safety. At the same time, how well the organization is doing at preventing incident or accident within the city. So we were looking to the combination between lagging and leading KPIs of the safety performance to look to our performance. And you know, measurement is an important part of any management process or any even a new process, and form the basis for continuous improvement. So this was our base to look to the leading and lagging indicators and what kind of KPIs we would like to study and we would like to prevent to our patients. So we move to the leading and lagging indicators. Leading and lagging versus lagging indicators, it's a very important concept, even in our KPI, in the KPI institution, focusing a lot on this concept. Because leading and lagging KPIs provide a systematic thinking on designing and selecting KPIs for our balance scorecard or even our dashboard. So in order to have a holistic overview on the performance level within the Zero Harm program, we set our leading and lagging indicators. So what is leading indicators? It's the measure things that address what can create future value, such as patient outcome and patient injury, and this will spend time on deciding what is the leading indicator for us. Then we move to the lagging indicators. We look back at the past performance and we think what kind of KPIs could affect our leading indicators, and we need to work on this. Then we selected 4 KPIs to be under our zero harm program. We were focusing on percent fall with moderate to severe injuries. We were focusing on percent of hospital-acquired pressure injuries, stage 2 and above. We were focusing on number of hospital-acquired infection, any kind of infection, and the number of medication administration potential error. So by using the prioritization tool, we have identified those KPIs. As I have mentioned to you, we have a special organization and we are not working in an acute hospital that you can select all measures. We have selected a key measures or a key KPI could serve the patient and really prevent a harm for our population. So after that, we move to draw our map and our zero harm map to look to the leading and lagging indicators. So we started with our KPI or the selected KPI. So first, we decided the 4 leading indicators, which is medication, hospital-acquired associated infection, hospital-acquired injury, stage 2 and above, and percent of fall, moderate to major injury, or we call it the fall adverse event. Then we were studying what kind of lagging indicator could affect each KPI. So we were thinking in the medication, the percent of staff attended the annual competency definitely could affect our KPI. Then percent of staff passed the yearly pharmacological exam could also affect and decrease the number of medication error. For our hospital-associated infection, definitely the hand hygiene, one of the key lagging measures could affect our HAI, and the infection control surveillance and use the surveillance, this also affects our HAI. For our HAPI, stage 2 and above, we are having the inter-rater reliability assessment as an indicator under our monthly reports, and the prevalence HAPI rate also, and we are having those KPI benchmark under the National Database of Nursing Quality Indicator, which is the NDNQI. When we go to the fall adverse event, also we are using the inter-rater reliability assessment on a quarterly basis to assess the effectiveness of the tool with the staff, plus the percent of completion of fall assessment on time to our patients. Then we move to the number of activities carried out during our zero harm journey, and we will speak about this one in details later on. We have carried out number of activities to support our zero harm program and to support the quality culture within the organization. After that, we move to select the level of harm for each KPI. We cannot move without selecting the level of harm, and this was very important for us to have each KPI and to train the leader to consider this within our zero harm program or within their daily operation action plan to work on. So for the fall adverse event, we said we will take level moderate or major or catastrophic. And for the HAPI, stage 2 and above, which we exclude stage 1. For hospital-acquired infection or associated infection, we include any kind of infection that the patient will have during the hospitalization period. And for the number of medication administration, 3 levels were with us, category G and category H and category I. We were having the level of harm for our KPI through the Saudi Safety Center, and we used the taxonomy tree within our zero harm level. After that, we decided to build a strong culture. We said we will build a strong culture of the safety culture within our organization before start using the tool of the zero harm. So first, we decide to engage frontline with us, to engage frontline in decision making. So no PI project will be started unless 50% from the member frontline from the unit Frontline will give us the best solution or the best action plan because they are familiar with the daily operation that they are providing to their patients. Listen to the customer voice, a major step in any project. Listen to the customer voice, even staff voice or even patient voice. Listen to their need and listen to their challenges. It's very important and one of the essential steps to initiate any PI project. A preventive action through PIPs, and we will speak about this later. We have initiate a performance improvement project with a list of action during our preparation for the zero harm. Then, just a minute.
In the meantime, I think we can think around which questions that we can pose to, is it Miss Lina Mohammed Obaid? Okay, there she's back. Thank you very much for being patient. Thank you.
Okay, because I'm trying to move the mute and I cannot. Okay, then we to build a clear vision while implementing any action that could support our zero harm and use automated reporting system. This was one of the essential steps by providing to the staff automated reporting system. They can report any kind of incident or even any near miss within their area, and to have it on a one page that they can report immediately without any challenge. Integrate just culture within the report system. And as I have mentioned in the beginning, we have integrated our just culture within the reporting system to support leader and to support the staff. We don't want to use a blame culture. At the same time, we need to have accountable staff responsible for their action. So just culture was our action for this. Empower leader to implement the just culture guidelines and sustain the improvements. So after each action or each project, we implement or initiate a sustaining plan to ensure that the action will be sustained in the unit. During the zero harm and for the reporting, we have added the number of incident reports to our balance scorecard. You know, one of the major risks or one of the risks from the zero harm is underreporting, and to consider that and to look for, to study this, we have added the number of incident reports to our balance scorecard to see the trend of incident reports on monthly basis to avoid any underreporting. And we were able to sustain the number of incident reports during implementing the zero harm within the city. And as you can see in the graph is reflecting increase in the trend of number of reports on monthly basis. So then we move to the promote zero harm culture. And as I have mentioned, we initiate a preventive number of preventive actions for each KPI to ensure that we are having a safety culture within the city that could promote the zero harm culture as well. So we start from the medication and we initiate a safe medication administration performance improvement projects. The time frame for this one was over 8 months before implementing the zero harm program. It was also interdisciplinary projects between us and between nursing, pharmacy, medical affairs, and more than 17 items of action plan have been completed. More than 25 education sessions for the staff have been conducted, plus design Arabic and English education posters to speak with the patient and to speak with the staff and to remind them. We have initiated a 90 days campaign as a competition between the unit and initiate annual mandatory pharmacological exam for all staff nurses with a score of 100% to allow them to give the medication. Plus, we use the system to improve the transcribing step and the administration step by activating the name alert sticker. If we have two patients with the same first and second name, to activate high alert alert on the system, and look-alike, sound-alike medication. Then, during the project, we have really a significant impact in decreasing number of medication error. And as you can see, the graph is reflecting really a significant improvement starting from August 19 up to now. We were unfortunately having 2 incidents within this period. First was because of reckless behavior, as we are using just culture integrated with our incident report. So it was a reckless behavior for the staff. And the second one was because of the system error in the transcribing. But after that, we were able to sustain a 0 number of medication error due to nursing administration error. Then we move to the second one, which is prevent or percent of hospital-associated infection, and we were focusing more in CAUTI or catheter urinary tract infection. And as I have mentioned before, our city is different than acute hospital. Most of our cases is brain injury cases or spinal cord cases. So they are using the catheterization most of the time. And catheter urinary tract infection, one of the major risks during their hospitalization. So we were thinking during our project to think how we could decrease the number of patient days, how we can decrease the CAUTI rate. So we initiate the performance improvement projects over 9 months. It was also interdisciplinary projects between nursing, rehabilitation department, and medical affairs department. More than 14 items have been completed, and we did many education sessions to the staff. Also, during the projects, we have introduced a new evidence-based practice, which is Houdini process. This Houdini process is allowing nursing to remove the catheter from the patient without physician order. And this really helped us a lot during the projects. If you can see here, this is our result. During the project and after that, we were able to decrease the number of catheter days from 1,072 days to 800 days. And if you can see in the second graph, even the p-value is reflect as statistically significant in our results by having p-value equal to 0.014. The third one was prevent fall adverse event, which is prevent moderate to major and catastrophic level of injury from fall. And this was also interdisciplinary projects between nursing, medical, and rehabilitation department over 6 months. More than 10 items of action were completed, and we have designed Arabic and English education posters to the patient and to the staff, conducted more than 30 education sessions to the patient and to the staff within rehab department and nursing department. We have scheduled a special session for the mother in the pediatric units, because in the pediatric units sometimes staying with us more than 3 to 5 weeks, and the mother, one of the sitter there. So we have set a schedule for them to educate them about the fall and the safety measures that they need to implement for their patients within the hospitalization periods. So we were focusing within the fall more on the education rather than changing any equipment. As a rehabilitation hospital, we have a good number of equipment, we have a good number of safety belts, we have a good number of helmets for our pediatric patients. But to educate the patient, to engage them with us, to prevent really the injury for such cases, is very important. And alhamdulillah, we were able to decrease and to have significant decrease once we have started our project, and to have really a safety culture. Our aim is 0, and inshallah we will be able to reach for that. but at least to have a safety culture reflect the safety of the patient. The last project was to focus on a hospital-acquired pressure injury and to prevent this. It was over 3 months, months of action plan. We initiate alarming system, especially in ICU, alarming the nurses to turn the patient to prevent any kind of pressure injury. Intensive analysis by using Pareto was for, we initiated for each case to look for the reason of having this pressure injury. We initiate a prevalence surveillance, benchmarked with other hospitals joining in the NQI, and conduct staff education for HAPI. And we were able to sustain the improvement or to be within our goal of having less than 1% as a HAPI rate within the hospital. To implement our action, we develop our After implement the preventive actions, we move to our zero harm data collection tool. We design a tool to our leaders, and as you can see, to facilitate the journey of zero harm and to help leaders in detecting the harm of incident, we have developed or initiated this tool to cover 1 year in each unit. This tool is to detect any harm incident from in the whole year with a certain legend, and those legend is covering the 4 selected KPIs every month. Then also we have designed a space for the level of harm as a reference to the leader while they are calculating the harm incident, so they can take the level of harm from the tool itself. And we have select or put for them a guidelines. These guidelines will help them if they need to move for action or no. As you know, zero harm concept, zero harm is a new concept. If you search for any kind of tool, there is no tool could help you how to calculate or how to use the number of days. So we have created our own tool through a quality team and nursing leaders. We created our own tool that could serve us in the whole year, and we can count the number of days free from harm. Then we move to the zero harm status. We have initiated this tool in January after completed all our actions and ensure we have a strong culture of safety. We release our tool in January 2020. So this report is up to April. In the beginning, we were having less number of units with a zero harm. But after building a strong culture of safety and a list of preventive measures, we were having many units completing the month without any harm. So we have created our zero harm dashboard, and this dashboard, we are sharing this dashboard on a monthly basis with each leader to look to the status of the unit and to decide if they need an action plan or they are within the green area in the tool. So the first graph, when we have studied our results, we found in 2019, if you can see, we have less number of units were able at least to have a 3 months without any harm. We have only 2 or 3 units were able to have a completed 3 months without any harm. Most of the unit, the average of the unit, less than 30 days free from harm. After the strong culture and after we implement, we were able in 2020 to have a good number of units free from harm and to achieve or to discharge the patients without any kind of harm. So comparing the percent, the percent unit with more than 3 months free from harm between 2019 and 2020, on the same period, January to April 2019 and 2020, we found that in 2019, 90% of the units were able to sustain a zero harm only, while in 2020, 43% of the units were able to sustain 3 months free from harm from our patients. So as a percent of improvements, we were able, the unit, after using our tool, to have, or at least to have, 62% of improvement in preventing the number of harm incidents within the percent or within the period of January to April 2020. This is a new concept for us, and this is a new journey. We are still aiming to have more KPIs and to add more KPIs. As per the prioritization for us now, we have selected 4 KPIs with a certain level. Any organization is aiming to have more KPIs and more measures, but to be realistic, we decided to start with those KPIs, and in the future, we will increase the number of KPIs, and we are aiming also to have a zero harm in all KPIs. So as a conclusion for us, reporting culture can be sustained even with implementing zero harm by having staff engagement, empower leader, even implement just culture. We can aim for a zero harm. So this is my presentation for today. I hope it was clear.